recently presented at the ASH 2023 meeting, treatment effectiveness with venetoclax-based therapy after BTK inhibitors in CLL. This is an international real-world study, and data was collected as a part of the CLL collaborative study of real-world evidence, a retrospective observational study of 23 centers, and adult patients diagnosed with CLL, SLL are eligible if they receive venetoclax-based treatment, either in monotherapy or in combination with Rituximab or Obinutuzumab after discontinuation of a covalent BTKi-based regimen. And baseline characteristics at venetoclax-based therapy initiation were summarized descriptively. Clinical outcomes following venetoclax-based therapy initiation included overall response rate, as well as time to next treatment or death, and progression-free survival. So we looked at overall response rate, time to next treatment or death, PFS, and both time to next treatment or death and PFS were calculated by Kaplan-Meier. And the outcomes were reported for the overall population as well as for the population who got venetoclax in second line after prior one line of therapy, and those who got venetoclax third line or beyond after second or more lines of therapy. So, what we noted is of the 184 patients, 127 had a documented response, and the overall response rate was 78%, which is really high. Of that, 43% was complete response. So you can see high response rate of venetoclax after prior BTKi treatment, and the median time to next treatment or death across all patients was 39.5 months, with a 12 and 18-month rate of 82% and 72% respectively. So that was the overall group. Then we looked at patients who went from first line to second line, and among 65 patients, 44 had documented response and with venetoclax-based therapy post covalent BTKi, and the overall response rate here was again high at 84%, and the median time to next treatment or death was not reached in this group. The 12-month and 18-month rates were 85% and 74% respectively. So again, a very high response rate here. The complete response rate was 55%. And then when we looked at patients who got venetoclax in third line, that's going from second line to then third line, again, there were 67 patients here, of which 46 had a documented response, and we saw an overall response rate of 78%. The median time to next treatment or death was 42.2 months over here, with a 12 and 18-month rate of 83% and 76% respectively. So we also looked at patients with or without prior chemotherapy or chemoimmunotherapy, and we saw similarly high response rates, as well as time to next treatment or death was very similar similarly around 44 months actually in this group of patients. Those who did not have chemotherapy exposure, the overall response rate was really high at like 89%, but the number of patients in that group was quite small. So what we can conclude from this very unique analysis, because for the most, the reason I say unique is that we don't have too much data with venetoclax after prior BTKi in the clinical trials. Most of these patients had failed chemotherapy or chemoimmunotherapy and then received venetoclax, as was in the Murano study. But here we are talking about those who have failed BTKi or either relapsed, refractory, or intolerant to BTKi and then got venetoclax. And in this large real-world study, we've shown that venetoclax-based therapy is very effective with high response rates, either in second line or third line therapy following BTKi discontinuation. And these results support that venetoclax-based therapy is associated with durable remissions as well after covalent BTKi discontinuation, even in patients who have had chemotherapy or chemoimmunotherapy in the past. And then venetoclax was well tolerated with only 17% of the patients needing a dose reduction in venetoclax. And as the CLL treatment paradigm continues to evolve in terms of breadth and available treatment options, clinicians can use these results to inform their clinical practice. We are going to do further analysis with larger cohorts and longer follow-up to provide more data in this important body of work. I do want to point out a few limitations. It is retrospective data using patient charts, so there can be potentials for some data entry errors, and this sample size is still small. But as I said already, that we will continue to grow this body of evidence with more patients and longer follow-up.